The lap band is a device that is fitted just below where the stomach joins the esophagus. It's lined by a balloon, and we can adjust the size of the lap band by injecting into a port that is buried under the skin attached to the rectus muscle. If we wish to remove fluid from the lap band, it is a simple procedure that can easily be done in the office or in the emergency room. This patient has had a lap band, and we can locate her port by looking for the largest incision on the abdomen, which in this case is in the left mid-zone. If you are having trouble locating the port, it is possible to ask the patient where they normally have their adjustments, and usually they will know. It is usually easier to feel the lap band if the patient is positioned with a pillow under the small of their back, forcing them to hyperextend the lumbar region. I firstly feel for the port and start caudally and work my way up towards the patient's head. With the side of my finger, I can now feel the caudal end of the port. If I bring back the benchtop model, you can imagine that the port is sitting attached to the rectus muscle, buried under the skin, with the tubing that connects it to the internal device running back up towards the patient's head. Therefore, anytime I use the needle, I want to start caudally and work my way up towards the head to avoid the risk of damaging the device. This is a sterile technique, and we prepare the skin with either chlorhexidine or a betadine solution. To access the port, we use a non-coring Huber needle as well as a syringe. If a Huber needle is not available, then a normal 23 gauged hypodermic needle may be used. Now that the skin is clean, I again feel for the bottom edge of the port, which in this patient I can feel here. I ask her to lift her head off the bed to tense the rectus muscles to stabilise the port, and now feel the port between two fingers. I then insert the needle attached to the syringe perpendicular to the skin, and very easily find the diaphragm of the port. To access the port, I ask the patient to lift their head off the bed and again feel for the caudal part of the port. Often I stabilise it between two fingers, then I insert my needle perpendicular to the skin and feel for the diaphragm. If I'm in doubt, I tap or walk the needle until I feel the clear difference between the plastic of the port and the silicone of the diaphragm. I now withdraw the fluid. You can relax your head down. In the emergency situation, just remove all fluid. It's important to hold on to the needle as you remove it from the patient, otherwise it sometimes detaches. I would typically then place a band-aid over the area that's bleeding and confirm that the patient can now swallow with more easily by giving them a glass of water.